Fine.
Actually, you probably get the experience.
Yeah. Just let me do that.
Didn't hear any of that.
Let's
probably go back
It's just like much more
All right, we'll get started. So you guys can finish your checks, do whatever you need to. Sorry it's a day one training, but you know how March is.
Yeah.
So we're gonna go over gunshot wounds. This is gonna be kind of a group discussion, kind of what you guys have been on, what you've seen, what your assessments is, and it's just completely different on many different factors. If you've seen this lecture I did back in 2022, it's a lot similar. I just went and changed a few things, different videos. Some statistics from the CDC. So roughly about 46,000 people have been killed by firearms in the United States. Suicides equal about 27,000, homicides 17, and unintentional about almost 500. So that's just rough estimates. In Utah, with 2020 versus 2023, there's an increase almost 100. Majority of those are suicides. So Utah is one of the highest states for suicide rates, and firearms happen to be one of the best methods. Different ways that gunshot wounds can cause damage. So laceration and cutting, as the bullet punctures skin, tissues, organs. Cavitation, the bullet will create a cavity inside the body that can rupture organs, displace tissue, and can cause damage that way. And then shock waves either in front and to the sides of the bullet as it enters. These are just different, your typical calibers, and they're pounds per foot, they're foot pounds. So you can see these are most of your common rifle rounds, and then these are your common handgun rounds. And with these, honestly, you can see any of them. And how would that change our assessment? Is this a question or an answer we should be giving the ER?
Yes.
About internal damage with that velocity.
Yeah. So I
You
mean,
can exit wounds also with some, obviously, the rifles.
yeah. You're gonna have more of an exit wound with rifles. You're gonna have more cavitation. You're gonna have more velocity behind those rounds. And they just
kind of depends where the energy is getting expelled. Because a rifle you might just get a straight through and through, whereas a pistol round's probably going to impact, and you might transfer more energy in the body that way.
100%. You know, was it a full metal jacket round? Was it a home defense round? Oh, was it a hollow point? I mean, you shoot someone with a full metal jacket versus a hollow point, that definitely could determine whether that bullet exits or not. If you see an entrance wound and no exit wound, you know, that could change our assessment. Bullets will also deviate their path. So you might see an exit wound that doesn't line up to the entrance wound. They could ricochet. Like, it's just so dependent on how that bullet wants to act. Because it's going to depend on caliber, distance, velocity, what type of round it was. But ultimately, we want to make sure we have a good understanding of what type of caliber it was, especially for the hospital. Was this a handgun? Was it a rifle? You know, was it, because a 22 is going to be a lot different than a 45, and then a 45 is going to be a lot different than, you know, a 30-30, a 30-06, and especially where it hits. And gunshot wounds, you know, it's either going to be like, we're all hands on deck, and we got to do some stuff to save this person, or there's nothing we can do. And then there's going to be some where it's like, we're just going to bandage it and go, and they're pretty much stable. You know, you have accidental discharges when they're cleaning their rifles or their handguns. The other day we had one in Clearfield, the guy shot himself in the hand with a 9mm. So he blew out his middle knuckle, and his middle finger was bent, and it was completely white. So he must have, I think he severed that artery, that middle finger, but that was his only injury. His knuckle was blown out and this middle finger. He had all of his other fingers were intact. He could move them, he could feel them. Just that middle finger, I'm like, well, I guess you can't flip anyone off with that hand anymore. This is just a little video. Last time I did handguns. This time it's going to be rifles.
Go. In 3, 2, slow down.
Wix gives you the power of AI to build the website you need.
YouTube rat or what?
Ballistic torso. Go. Ready when you are. Alright. In 3, 2, 1. There you go. Perfect. Didn't even slow down, barely at all.
You can see how that bullet moved.
I love that you can see it right there opening up. It's got stuff to do. It's gonna be. And what's cool is it opened up just in time to tear through the organ. Awesome. Yeah. Well, it's definitely different than a handgun. It doesn't necessarily make a bigger cavity through the whole thing, but it opens up differently and it just tears right through. It's going out the other side, no problem.
I don't know why I kept
Didn't
full
even
screen.
think about slowing down. All right, let's shoot the rib cage. All right, 300 blackout through the chest. You're hot. Ready when you are. Go.
It's slow.
In 3, 2, 1. Perfect. Weapon is clear.
Great shot.
Sometimes bullets can tumble. So that's like they kind of categorized it with just laceration, but sometimes they can even tumble. There's our snapped rib right there.
I mean, that is like a almost perfectly circular hole in his skin. And then you can see where it starts to flange out.
This is a beautiful exit hole.
Yeah?
Look at that.
Pushed on the front second up.
No spiders were harmed in this video.
All right, let's see what difference the 6.5 Creedmoor has. This is 6.5 Creedmoor against a ballistic torso. We are hot. In 3, 2, 1. Oh man, that was catastrophic. Okay, this is clear. So the entrance hole was pretty small, but I think the cavity in the body was really big. To me, that one looked more like it pulled stuff with it. There's a lot of stuff coming up. Usually it kind of goes out of the way. It just nicked that rib. The two above it snapped as well. That's a pretty good opening. You can see that those are all broken in there now. And that one's just in. These ones I can
suspended in flesh.
Yeah, I can feel resistance on these ones. That's just nothing there.
Man, there's just so much. What in the world happened?
That's from the 6.5, I think. Yeah. What is that? We've never gotten this before.
You know what it is?
I bet it was a piece of expansion coming off and just flaking out a little bit. I think that kind of proves what we were talking about. I think that's it pulling his lower organs through.
Yeah, because that looks like organ material that made it all the way in the back.
I think it pulled it with it. That thing is powerful, man.
Let's send one through the chest. See if we can hit this bone again.
Knock that out.
Yeah. 6.5 Creedmoor through the chest. And whenever you're ready. Okay.
In 3, 2, 1.
Oh man. Even not seeing the high speed, I can feel that that's so much worse.
This is how I can just see your keys out of
And oh, look
what it did to his whole sternum.
Oh, you're right. It just cracks up the whole thing.
So hitting it over there and all of that moving around we talked about, it broke off at every junction. They're all floating ribs now.
Basically. That's a massive laceration.
Yeah. I wonder if that, like if our skin would do that, or is that more like one of the downfalls to the gel, maybe?
Maybe. Because I feel like when somebody gets shot in real life, they keep bleeding out and bleeding out
Yeah.
if the laceration's that big. But that's because there's blood vessels all through your muscles and your skin, so that's the only difference. All right, what do you think about a mag dump?
Oh yeah.
Let's do it. All right, so I'm gonna get it in sight, and I'm gonna say 3, 2, 1, bang. Okay, 3, and that'll be us both shooting. You keep going. Okay.
And you're going sternum.
I'm going dead center sternum. 3, 2, 1. Nice. I almost can't tell where all the shots are.
Yes, that was from steps.
I'd say that was another successful video. Carnage level, pretty high again.
They also stabbed it.
So especially when we're actually hitting bone.
They ran in and
But
stabbed
just the expansion alone caused ribs to crack, which is pretty cool to see.
Absolutely was. And quite a few of them. It wasn't even just like, one. It was 3 at a time on the one, I believe it was.
You guys know the slow-mo is pretty much what we're here for. Everything looks much more devastating.
Look at that rooster tail.
That's kind of just able to show you, like in real, like how you can see the cavitation, the penetration, and all that, the different types of injuries that can occur. So, if you have someone who's shot in the abdomen, do you think we should be also looking for, injuries into the chest cavity? They could rupture their diaphragm, rupture a lung, break multiple ribs. Just because that injury is isolated to the abdomen doesn't mean that doesn't cause damage to other systems. So it's kind of try not to get tunnel vision into, oh, it's only in the abdomen, or it's only in the leg, or it's only in the arm. I won't show you B-Shift's video. They have a different video because they've already seen the first one. If anyone has a problem with images, by the way, just look away. Just fair warning. These are different types of patterns you'll see with firearms. You might see soot on the hands, soot around wounds, and then intermediate to long range, you'll see more carnage, I guess, is the word. But our guy that was shot in the hand, you can see the soot went all the way around his whole palm. So that's just something to look out for. Whether you're suspicious that it's a suicide, you can voice your concern to PD while you're there, like they have soot in their hands or they don't have soot in their hands, or you could just kind of like, that's a PD issue, we'll leave it. Our assessments generally shouldn't change. Obviously, control any major bleeding, airway, breathing, circulation. What are some ways that we can control the airway or we should be monitoring in our airways?
Jaw thrust.
Jaw thrust?
Talking to us, right?
Are they talking? Yeah. Is this an upper airway? Might they've been hit in the neck? Were they hit in the chest? So are we looking more of an upper airway issue or a lower airway issue? Is this a patient that can maintain their airway or not? Are we going to get ready to intubate or RSI this guy? Supraglottics, just oxygen transport, or they have no airway issues, is isolated to a limb?
Positioning's a big one.
Positioning.
Suction.
And a lot of these patients are going to be distraught. They probably won't even want to answer a whole lot of questions, or they're going to be very upset. Like our guy in Clearfield, the North Davis girl asked him. She's like, "Sir, how are you doing?" He's like, "I shot myself in the fucking hand. How do you think I'm doing?" Like, he's got a point.
Yeah.
How's your day going?
Is it the tail?
I don't even know where the damn dog is.
Is it the tail?
Did she come back for me?
Breathing.
No, there is nothing.
Do they have a flow chest or an open chest wound? Is this something that we can maintain? Hurry, throw a chest seal on, move on to your next issue. Just different things to look out for. Do they have lung sounds? Are we going to be doing needles? Maybe thoracostomies in the future. Maybe not. Any major bleeding? Are we throwing tourniquets? Do we have to give TXA? Are we doing wound packing? Has anyone here wound packed a wound? So we'll talk more about wound packing, and hopefully in the future I can get Roxanne to buy a wound pack model. Kind of go through that and different techniques of wound packing. Are their vitals stable? Are they not stable? Do we want to dump fluids in this guy or woman? Or not?
Unless you're running numbers, it's 90% dudes.
Should be doing neurological assessments. Is this a gunshot wound to the head where they have vitals? So how often does that happen? More than we think. You know, you show up and it's an isolated gunshot wound to the head, but yet they have a pulse. They're somewhat breathing on their own for the most part, maybe not great.
I think a big one with that, right? A lot of times when you have self-inflicted, it's one of those things where you're like, they may be a donor, and so you still want to throw the book at them because obviously they've made their choice and they're not probably going to be viable of any kind, but there's plenty of other people with good care that we can provide. There's plenty of other people that may have the opportunity to live based off of their decision. So that's one thing that we've got to be very, very, in the moment, you can be like, whatever, right, agonal rests. You could definitely provide diminishing treatment and maintain initial stuff, but you can also provide opportunities for great oxygenation and all that other stuff. They could heart transplant, they could pretty much gut the person and use everything if they're a donor.
Right. And that's what's great, like my dad always said, why he loved cardiology so much is he's like, the brain can't function without a heart, but the heart can function without a brain. And so, as sad as that individual who went through what they did to do what they did, there can still be a positive outcome for the 12 or how many people they can save on the transplants. Motor extremities. Was it possible?
Ambulance 53. Response to 29 Alpha. Traffic accident.
Is it possible that they might have been hit in the spine?
In Farmington.
Is it possible they have neurological deficits caused by damage?
See you guys tomorrow.
So that's why we want to do a good, thorough neurological assessment. You might see a gunshot wound to the abdomen, but they can't move their legs. Is it possible that it hit the spine? Definitely. Make sure we do rapid assessments. Keep these patients warm. And that should be for just any trauma patient. So my medic students in here, there's lots of triads, right? What's the triad for trauma?
Hypothermia.
Next to
I'm still learning.
I think someone must have said it, but I think I missed the third one. I heard hypothermia and the coagulopathy.
Acidosis?
And acidosis.
There's hypocalcemia. There's 4 now.
Sure.
Yes.
The square of death.
Yes.
The square of death. I like the triangle of death, though.
Triangle. It looks scary. It's pointy.
Triangle is much scarier.
Yeah, it's much scarier.
Square.
That's like pointier though.
Oh my God.
That's an acute angle.
It's got a angle.
Okay. It's an acute angle right here.
Oh, rhombus? Dude, it's still pointy.
What's the area of that?
A lot of this is this is going to be more long term for that patient, but we can definitely help with hypothermia to make sure that patient stays warm. Because once you get behind the 8 ball, then it's hard to keep up. But as far as like acidosis and the coagulopathy, that's going to be long term for the hospital. But definitely just something to keep in the back of your mind.
I'd just say ish on long term, because like if you think about the pH of our saline and stuff, we can make them pretty acidotic with that because it's lower. So we don't want to be dumping tons of fluid in them because we're changing that. And then if we, obviously give them too much fluid, we're messing with I can't even say it. I got him whispering and you said it. But that third one, we're messing with that as well. So our care, I feel like, totally matters in all 3 of these. Don't dump too much fluid in them because you've got to recognize the pH of that and things like that, because we can definitely screw all those up real quick.
Oh yeah, for sure. And like Mikkel was saying, like there's studies coming out that saline actually causes worse for acidosis, and that now they're preferring lactated ringers on traumas, but yet that's still an ongoing study, even though you can't use LR on blood products. But now saline has an issue long term with acidosis.
It's another thing too, pulling there, making sure your IV warmers work.
Mm-hmm.
Because if you have somebody with trauma and you throw a 60, 55 degree fluid in their body, you can definitely make it worse.
Yeah.
Than pulling a 100 degree, so.
And I think with our assessments, I was talking to Chief Cook before this, and he was telling me a scenario that AirMed was doing where PD hit the suspect with a car and then shot him.
Nice.
So when EMS got there, they got so tunnel visioned into the gunshot wounds that they completely missed the guy had a pelvic fracture from being hit by the car. So that's just a bigger story. Like, we shouldn't try to get tunnel vision, and I think all of us would be guilty of it. You hear gunshot wound, you see it, and you get so focused on that gunshot wound that now we're missing the grand scheme or the mechanism of injuries that have been going on. And I think it's more common than we believe it is. Because in Roy, they had the same thing happen where PD hit the suspect with a car, and then he got shot. I mean, he was DOA, but...
Garrett, that just comes down to basics. We have a primary assessment, and we should always do a good secondary assessment. And our secondary assessment is to find all of that stuff after we've initially recognized the immediate life threat. So if we're doing just basic, that's not an ALS skill, it's not a paramedic skill, that's something that we all learned in basic EMT school.
Right.
So it shouldn't be, it's not something that should get missed because it's something that we learned on, in the first week of even going into this field at all. Is that we do a secondary assessment, we had to do 100 of them in school, and we've probably done thousands of them out here. So we shouldn't be missing that stuff just based on if we just do the very basic assessment, you're gonna find that stuff.
Right. Right. And nothing in here, I think, is specific to just a medic. Everything in here has been an EMT skill, and I think that's what a lot of our gunshots are going to be, are just bandaging, controlling bleeding, managing airways. And you can do any of that at the EMT level. You know, this isn't just an ALS skill or scenario. Like we can, most of our procedures are going to be BLS skills, and BLS saves lives, right? I believe that. BLS saves lives. Tourniquets. Make sure you put it above the wound, not below it. And you might see PD. PD just, they see tourniquets. They get a rough little, like, hey, this is how to throw a tourniquet. If you get on the scene and PD is throwing a tourniquet, is it okay to loosen it a little bit? This is specifically like, what do you guys think? You know, should we make sure it's really an arterial bleed, or was it a venous bleed that is just they got worried and threw a tourniquet on?
Is it properly placed?
Yeah, I guess. Should we just take a second to look at that tourniquet, or just be like, they threw the tourniquet, we're going to leave that, there's no bleeding?
Assess to make sure it's properly positioned and properly tightened, but we'll just leave it where it is.
Yeah.
Let the doctor figure out if it's venous or arterial.
It's always one of those, if you operate under the rule of thumb that the tourniquet's gonna hurt worse than the injury, that's when you know it's the right amount of tightness.
Mm-hmm.
Is that the tourniquet hurts worse.
If the bleeding stops.
Yeah, I think it's just per provider. Like when I was out in Weber County, like it wasn't uncommon for the Ogden medics to loosen tourniquets PD put on to make sure it was really an arterial bleed. I'll leave that up to you on if you feel like that's right or not.
The big thing is they're not going to be able to discern a PD placement versus an EMS placement, so it wouldn't hurt to make sure that it's put in the right spot, because by the time when you take them, you pretty much own it. So if you don't want to eat crow at the ED level, make sure it's placed where you want it, whether it's high and tight or a couple inches above the injury, whatever.
Right.
Whatever one, just know you're owning it from the second that you take the patient on. So.
Right. At what point can we not put tourniquets? In what areas of the body can we not put tourniquets?
The neck. Junctions.
Junctions? That's the big one, just junctions.
I mean, the neck is a big one.
The neck's a big one.
The biggest, actually.
So yeah, junctions. And this is where our wound packing is going to come in. Wound pack the neck. Yay or nay?
Or tachoderms.
Tachoderms?
Like if you're getting sub-Q air to an injury, you can throw a tachoderm on it.
Yeah. Stick your finger in. We'll just leave it there. Does anyone not know how to do wound packing? Or a general idea of wound packing? I think fire engineering had a video on it. Pretty simple. But yeah, just anywhere in the junctions is where we're gonna, and they make different tourniquets, like the military has junction tourniquets, we don't, so. But I didn't know that was a thing, it's a thing. This is just a video on wound packing, but I feel like unless you guys absolutely want to see it.
Let's watch it. Sure. Review. Let's judge it.
You want your MD as early as 2029? Oh, that one went full screen.
In the last few years, the military has really been pushing the envelope on how to control life-threatening bleeding. What I'm going to show you today is wound packing. When you pack a wound, you're usually doing it in a place where you cannot put a tourniquet above that. So it's going to be in one of your junctions, either your axilla area, your neck, or your groin area. Okay, so now you have your active bleed. So I take my gauze, I put a power ball, I stick it in, it's going to keep bleeding. I find my artery. It's going to be on the portion closest, obviously, to the heart. I just keep putting it in until I fill that hole completely up, stopping the bleed, going in and holding it like so, direct pressure, And once I put my hand here, I don't want to take it out, and obviously I'm not going to take the gauze out either. And if I need to add more gauze, I just add more gauze on top of this.
Pretty simple, right? Pneumos, so tension pneumo, whether it's a pneumo or a hemo or a hemo-pneumo.
Can we go back just a little bit?
Yeah.
We're just talking about the quick clot gauze.
So there's an idea that it's completely saturated, that you pull it out and restart.
Okay,
There's a thought.
gotcha.
Which is going up in the air.
If you're bleeding.
If you're starting and going and you're like completely saturated already, you can start
Allegedly.
allegedly.
Yeah.
So that you repeat the same process.
Right. I knew there was something to it, but.
A big thing is to make sure we don't wound back with the cause. Because if they go x-ray, especially joint areas, it might get missed. We've got to make sure that we have the, whatever the UV something or other when we're putting things in people's bodies to make sure that it doesn't get missed, because normal Acrylics isn't gonna pull up on a scan. So, we're patching junctions, make sure we're using the right tool. Or they might have it in their body for a long time.
Yeah. And this is going to be very short term. This is going to be something that they're going to go straight to the OR or even the IR suite. Because now IR is really big into traumas. They don't want to have patients go to IR. We had a lady get hit. She hit the barrier up at 89 and she had a pelvic fracture that lacerated her iliac artery. And Ogden Regional came and gave us like a report on what they did after, and they took her to IR versus the OR. So the radiologist went in and cauterized it just through imaging and like a cath lab almost. So he said that's really big right now in traumas. I guess it's got a very low infection rate. It's faster, it's safer because they actually just can see it through imaging. So he said that's really big right now. Or they don't even take a lot of their traumas to the OR. They start in interventional radiology. So I thought that was pretty interesting. And that's a 24, he said it's a 24/7 program. They always have the radiologist there to keep their trauma 2 cert. Anything else on wound packing you guys want to bring up? Different ideas, different techniques, if anyone has wound packed? No? Yeah.
Another thing you can do is before you're getting like your equipment out, if you add pressure, like a good spot would be like a knee. You can put, like if it's in the junction up here, you can put your knee on it while you're going and grabbing your equipment, or you're grabbing pressure. Just the big thing is start with pressure, but if you're by yourself or somebody's doing an airway at the same time, like you can provide pressure with other parts of your body. So I know in big, like when we do like rescue task force stuff too, a lot of times they'll tell you to put a knee or a foot if you're seeing something bleeding, to start with the pressure while you get your equipment.
54 is asking that we repeat that stuff from the crowd because they can't hear it. So go ahead.
Captain McCoy was just talking about just throwing like direct pressure, and you can put like your knee on that wound if you have to grab like a tourniquet or any other equipment you need, or if you're by yourself. Where'd you see that question? Did it just pop up?
Me. Sorry, no, he texted me.
Oh.
Direct.
Does that make sense, 54?
Is anyone even there?
There's a wave. There's a wave. So yeah, that's the video we watched. So pneumos, we're gonna needle decompress, maybe finger thoracotomies in the future, maybe not, who knows. But axillary is preferred over midclavicular. So 5th intercostal space in the axillary, or 2nd intercostal space midclavicular. What?
Nothing.
Bring it up.
Anterior axillary, sorry. Just think.
Okay.
Not just axillary, for anterior.
Thank you.
Welcome.
So air and blood trapped in the pleural space, and I don't know if Dr. O, I remember him telling me in medic school that he has only seen one true tension pneumothorax where they had tracheal deviation. So don't be tunnel vision if they don't have tracheal deviation, that they still don't possibly have a tension pneumo. So I thought that was pretty interesting. Open chest wound. You can either do the 3-sided occlusive dressing or a chest seal. Manage airway. I mean, all this is pretty simple, a lot of BLS skills, but stuff that sometimes we miss or we forget about.
When you're doing your chest seals, just make sure that you wipe the area clean, because if it's got any blood on it, those things don't stick. So, and you only got a finite amount of seals, especially if you have multiple gunshot wounds. So take a half second, grab a towel, dab it, make sure it's dry, then put your seal on, because if not, it's gonna just start peeling off.
Yeah.
She got bit by a pit bull. Her dad got pretty badly bit up, but she's got a sucking chest wound here. Her chest X-ray actually looks pretty good. She's got a bunch of lacerations here in her leg. I'm sorry, big girl.
You're not going to touch it. You're just going to show them. Okay?
Just kind of to show a sucking chest wound, open chest wound. TXA, probably one of the most important medications that we can give that will affect our patients long term for any bleeding. How does TXA work?
Inhibits the conversion of plasminogen.
Thank you, Michelle. So TXA, it's an antifibrinolytic, so it's typically your body wants to break down clots when they see them. This stops the process. It's not a blood clotter, but it stops that process so that your body can form clots to stop the bleed. In simple terms.
Yeah. I feel like that's where a lot of people get mixed up, is they believe that TXA makes the clot. It doesn't make the clot. It just helps our body keep our clots that our bodies naturally formed. What's our dose? 1 gram. When I made this is when we still had the vials and you had to mix it, but now it's pre-mixed. Thanks, Mark.
Nope, you just put that.
Yeah.
He's
always watching. He's always watching. So yeah, contraindications if the injury was over 3 hours, if our patients are under 14. If they have a known hypersensitivity, I got more questions.
Have you shot before?
Yeah. I got a few questions I want to know on how they know they have a sensitivity to the TXA. But I feel like we actually give TXA quite regularly. I feel like I've seen it given multiple times. I know you guys have seen it given multiple times. I think it works. I haven't been told it doesn't. I like to call this my Ben Wharton video.
Interesting.
This is my video that keep Ryan and Daniel focused.
Is it cartoons?
It might be a cartoon.
Sesame Street?
Gotta be anime.
It's got Subway Surfer below.
Your tomato plants work, but they don't work like Wealthfront. Cash earns nearly 10 times the national average rate in your cash.
I can restart it and turn back on again.
Oh, yeah. Oh, Brits know about that shit. Yeah, right. Brush your teeth. You said these are You received them? Yeah.
When a blood vessel is ruptured and starts bleeding, The body responds by forming long strands of a tough yellow protein called fibrin that traps blood cells and plugs the leak. This is called clotting. However, at the same time, it triggers another process, which is not always helpful.
This is why it's my Ryan and Daniel video.
It begins with these playful canines called plasminogen, but they won't be playful for long. The torn blood vessel has released tissue plasminogen activator, or TPA as he likes to call himself, and he loves causing trouble. Once TPA shows up, the plasminogen dogs get nasty. These hounds of hell are plasmin. The plasmin dogs tear fibrin apart, making the bleeding much worse. Of course, plasminogen activator inhibitor 1, or PI1 for short, could put a stop to all this destruction if she wakes up. And when Pi-1 does wake up, it's often too late. That's why we give tranexamic acid as soon as possible after bleeding starts. Tranexamic acid stops plasminogen binding to fibrin, sparing the clot from the plasmin dogs. And a nice blood clot can stop the bleeding.
Wow. Isn't that just the cutest damn video? So now we kind of have a general understanding how TXA works. But overall, in conclusion, gunshots can be very BLS skills, and that's what's going to save our patients' lives. Stop bleeding, different methods to stop bleeding. Don't get tunnel visioned into a certain area of the injury. Do thorough secondary assessments. Treat your patients appropriately. Pain management's great. And TXA. Any questions, any comments you guys want to bring up? Any ideas, thoughts, stories, complaints?
Just remember when you're doing your gunshots, check their back. Always check their back. That's always one that gets missed, no different than traumas. Just because we're really good at getting them on the stretcher, and then the disposition happens where we start transporting, we go wherever, and a lot of times we miss it. So take the opportune time to make sure we roll them. We're assessing their back every time because it's very easy to get missed, and you could look down.
Didn't somebody bring someone in? Is there a story about the cop found the doc found the exit wound? Yeah, I don't know if that was anybody in here.
We missed an entrance wound on the belly button. Didn't recognize until urine came out of it.
Oh, that's awesome.
Yeah. I mean, he was shot multiple times, but that one was a goofy, just a scenario that we just...
He was alive when we got him to the hospital.
Yep. And he was going to survive when he left
Mike,
in the
so
helicopter
offensive.
until they didn't let him, so...
They're like, unplug it.
Oh yeah, dude, it was bad.
You like geyser got
You're a piece of shit. See you later.
Yeah, it was bad.
So defensive, Mikey. So yeah, make sure you do good secondary assessments. Look for exit wounds. I like exit wounds because that means that bullet's not in there. At least if it's one shot, and I can at least know, like, oh, they're only shot once. But anything else? Comments? Complaints? All right, Garrett.
Thanks, Garrett.
I'm gonna go back to my Zans and White Monster. Where's my drink?
554.
Been hydrated?
Yes.
There's those stickers on you.
Keep it that way. Yeah.
Good for you. Good for you. Thanks, dude. That's good.
It's loud enough.
I like that idea. Look at this.
Please don't bite me.